welcome everyone to this fourth and last presentation in our series on hypereosinophilic disorders and specifically hypereosinophilic syndrome. I'm going to end this series with a more practical presentation, hoping to address a series of questions that as clinicians we all ask ourselves about really how to approach these patients. And the main objectives of this webinar, if you see my next slide. Okay, are first just reminding you that it's really important to rule out common underlying causes of secondary hypereosinophilia. And then once you've done that, knowing what is the relative distribution of the different types of hypereosinophilic conditions, being able to better navigate the diagnostic tools. I'm going to go through that in some degree of detail to identify hypereosinophilic syndrome variants, but also to detect damage, which is directly related to the presence of eosinophils in tissue. Then we'll try to understand one very specific condition, which is when you have pulmonary infiltrates and hypereosinophilia. There's a considerable overlap amongst these different disorders, and unfortunately, that is also often associated with an important diagnostic delay just because it's so confusing to put people into a category. And this diagnostic delay obviously hinders appropriate and timely treatment of disease. Choosing the best treatment option depending on patients, and we'll discuss a bit the eosinophil-targeted therapies and specifically the one that is currently approved for hypereosinophilic syndrome. And then I'll just mention in passing that there is a series of research priorities with respect to these different new treatment options. So these are my conflicts of interest. And the first couple slides are going to be really a brief reminder of a few of the presentations that you perhaps already attended within this webinar series. So first of all, I'd really like to re-insist on the fact that in the majority of cases, when you see a hypereosinophilic patient, obviously you're going to find an underlying cause, and it's not going to be hypereosinophilic syndrome, even if this whole presentation is all about that. And so on this slide, you basically have the three most common types of diseases upon which you will eventually stumble if you investigate hypereosinophilia. In our developed countries, the most common cause clearly is adverse drug reactions, not always as severe as stress, but you often see hypereosinophilia, some degree of hypereosinophilia and skin rash associated with a series of drugs. Then the parasitic infections, and more specifically helminthic infections, and then obviously different forms of cancer, whether it be hematological malignancies, but also solid neoplasms. And so I've already shown this slide, which really shows the main causes of hypereosinophilia. And obviously today, the focus of our interest is really going to be the rare eosinophilic disorders, namely idiopathic hypereosinophilic syndrome. But I will also mention eosinophilic granulomatosis with polyangiitis, which really, as I said previously, has considerable overlap with this syndrome. So this was the summary of this slide. Is you have to look for wheezes, meaning allergic conditions, worms, and weird diseases. And we're going to be talking about those weird diseases. You've also seen this slide already. What is a hypereosinophilic syndrome? Per definition, you have to have both blood and tissue hypereosinophilia. In the blood, more than 1,000 eosinophils per microliter, and in tissue, the pathologist has to be of the opinion that there are too many eosinophils. Sometimes this is challenging because activated eosinophils degranulate. You can no longer recognize them as such because they no longer have this eosin staining property, which is actually due to the fact that they have intact granules in their cytoplasm. So sometimes you have to do special stains to be able to show the recent presence of eosinophils that have degranulated and released those eosinophil granule proteins, which for the time being cannot be stained in routine, but which several labs do perform on a complementary basis. And a hypereosinophilic syndrome, you have blood and tissue eosinophilia, and because of this, you have to have eosinophil-mediated damage in these different tissues, and I went over the different forms of damage that you can experience. And then another slide, and this is the last one that you've already seen. Once you do have a patient who seems to have a hypereosinophilic syndrome, the next step is to be able to determine what type of hypereosinophilic syndrome this is. Is the eosinophilia clonal? In other words, is there some form of somatic mutation which is driving eosinophil expansion? Or is the eosinophilia polyclonal? Is this actually the result of increased presence of eosinophilopoietic factors? This is obviously what we'll be finding more commonly compared to clonal eosinophilia. But unfortunately, in the majority of cases, it's very difficult to be able to demonstrate that increased production of eosinophilopoietic cytokines. And this is really what is now really classified as a kind of bucket of different diagnoses, which is idiopathic or unknown etiology for the hypereosinophilic syndrome. So now with that short introduction, just for the few reminders, I'm going to really look at how we approach hypereosinophilia practically in the clinic. And the first step, really, when you have an increased blood eosinophil count, is to look for the known causes of hypereosinophilia on one hand, but also if the patient has symptoms, it's really important in parallel to look for possible consequences of this hypereosinophilia and make sure that the eosinophils are not causing severe, life-threatening, rapidly progressive organ damage. In some patients, things are going to be very obvious from the onset because in the same complete blood count, which is showing the hypereosinophilia, you'll be seeing other anomalies which clearly are driving you towards the diagnosis of a hematological malignancy. This will be the case if you see increased presence of other lineages, for example, basophils, neutrophils, monocytes, which will direct towards some other form of myeloid neoplasm, but also in presence of decreased red blood cells or platelets. Obviously, if you see circulating precursors or even if you see blasts, these are all anomalies which are going to make you send the patient to a hematologist to perform the appropriate cytogenetic analyses, bone marrow aspirates and biopsies and karyotyping studies to be able to treat that hematological neoplasm as best as possible. And we had the last webinar was really dedicated to those different treatments and those very specific disorders, and I will not go into that today at all. As I said, you obviously have to look for the underlying causes and etiologies, and there's a series of exams that are going to be performed more or less at the same time to be able to address these two important questions. In terms of etiology, obviously, you want to know what the drug history of the patient is, his travel history. Has the patient traveled or lived in a region which is endemic for a given helminthiasis? What are the risk factors for malignancy? For example, for lung cancer, for colorectal cancer. These are cancers that can potentially be associated with hypereosinophilia. In terms of additional exams, I'm going to go through that perhaps in a bit more detail on the next slide. I'm not going to detail that on this slide, but at the end of the day, with these exams, you're going to make the diagnosis of a potential underlying cause of hypereosinophilia or not. What are these exams? This slide goes through several of these different investigations with a bit more detail. For example, obviously, if you have a patient who has a pulmonary presentation, in addition to all of the other tests that you're going to be looking for parasitic infection or fungal colonization, you'll be running ANCA to make sure that this patient doesn't have eosinophilic granulomatosis with polyangiitis. Given the importance of recognizing these underlying myeloid malignancies, obviously, cytogenetic testing is very important. And as I said previously, there's also a subset of patients who have this lymphoid variant hypereosinophilic syndrome. And the best test to be able to detect these anomalies of their T cells, which are driving hypereosinophilia, is to do T cell immunophenotyping. In addition to that, the test that will be performed that will look for end organ damage and involvement, we'll look at the most commonly affected organs. And obviously, the heart is a very, very important target organ. I said in the first presentation that unfortunately, the very early stages of heart involvement are generally perfectly asymptomatic. So it's really important to have serum troponin tests to be able to this is a very sensitive test for myocardial damage, but also electrocardiogram and echocardiogram are equally important. And sometimes, even in some patients, it's necessary if you have a slight elevation of troponin to do a cardiac MRI, which is a lot more sensitive for detection of subendocardial inflammation. For the different complications with the lungs, you'll be doing a chest CT, perhaps also pulmonary function tests. If you have GI tract manifestations, you'll be doing endoscopy, eventually an abdominal CT scan. And as I said earlier, given the importance of cancer, underlying cancer in these disorders, it's pretty common to perform a FDG PET at some point to be able to detect lymphoma, but also the adenocarcinoma of lung or the digestive tract, amongst others. So this is a very, very extensive set of tests, obviously. Some of them are not always absolutely necessary, and they'll be performed on the basis of patient complaints, obviously. So once you have done all these different examinations and you think you have found the underlying cause of hypereosinophilia, you're going to treat this cause. And you're going to reevaluate the patient afterwards, because sometimes you thought you found the cause, but you actually haven't. And I can give you a myriad of examples that I have actually experienced personally. For example, positive serology for a parasite. It remains positive for a long period of time. And so the patient may no longer be actually suffering from that parasitic infection, may still have positive serology. You're going to treat that patient for the parasitic infection, make them come back in, and there'll still be this hypereosinophilia. So you have not actually found the underlying cause. Same thing for cancer. I remember once doing a FDG PET for a patient, found colorectal cancer. The cancer was treated, it was very early stage cancer. It was removed, and the patient remained hypereosinophilic. So even if you think you find the cause, it's really important to have the patient come back in to make sure that the hypereosinophilia has resolved with your treatment. If it has not resolved, then you're in the same situation as if you have not found underlying disease. And it is this point in time that you're going to evaluate for a hypereosinophilic syndrome, and particularly for the different variants of this disease. And this is a bit of a busy slide. Some of the things are already found on the slides that you've seen before, but I'd just like to highlight a few points. So one of the points is, okay, you ruled out secondary hypereosinophilia. This is when you're going to want to check for the underlying hypereosinophilic syndrome variants, namely the clonal disease variants, the T-cell-driven disease variants, and you're going to be performing a series of exams. These exams can be done for the most part actually on peripheral blood. For example, if you're looking for the FIT1-like1 PGF receptor alpha fusion protein, you're going to be able, gene, you're going to be able to demonstrate this on peripheral blood. You don't necessarily have to do a bone marrow to be able to pick up this fusion gene. So anyways, whether it be on blood or bone marrow, you're going to be evaluating the patient for these different clonal abnormalities. And another important clue to the fact that you might have clonal hypereosinophilia is the fact that the patients are often corticosteroid resistant. This is really something which should raise suspicion of a clonal eosinophilic disorder to a very, very high level. And you can see the different classifications, which have been discussed in a great deal of detail by the previous speaker. So those are the clonal eosinophilic disorders. Besides that, as I already mentioned, you're going to be wanting to identify those patients who have lymphocytic variant hypereosinophilic syndrome, because even if the initial approach to these patients is very similar to those with idiopathic hypereosinophilic syndrome, their prognosis is potentially different, and perhaps the second-line treatment options that you're going to be wanting to give them are going to be equally different. And then finally, as I said, many patients actually have idiopathic hypereosinophilic syndrome, and we're going to really go through the treatment algorithms for these different disease variants. I talked about bone marrow analyses, and depending on the type of literature that you tend to read, and I understand that here mainly there's going to be hematologists present for this presentation. So if you look at the hematology literature, people generally do bone marrow biopsies or aspirates in the majority of patients. If you, I mean, that's my personal experience as well, is when patients are referred from a hematologist, they almost systematically have had a bone marrow aspirate at minimum. Whereas if patients are referred by a pulmonologist, none of them will have had a bone marrow investigation, and it's up to me to decide whether they should have one or not. And I'm an internist, I'm not a hematologist, and I'm not a hemopathologist. But if you look at the literature in hematology, the bone marrow aspirate is something which is done pretty much upfront once the secondary causes of hypereosinophilia have been ruled out. And once again, this is really to be able to pick up those clonal eosinophilic disorders that I discussed. And it can be really interesting because even, you know, when you can't pick up the cytogenetic abnormality, sometimes the bone marrow itself is very informative. And I am not a hematopathologist at all, but on this slide, you can see two very, very different bone marrows. On top, a bone marrow with a more reactive hypereosinophilic aspect, and on the bottom, a bone marrow which is extremely perturbed with dysplastic cells. And even if this patient, and this was the case in this particular article, does not have a detectable cytogenetic abnormality, bone marrow investigation can be very, very interesting in this type of patient to say, okay, clearly something is happening in terms of myeloproliferation or at least myelodysplasia. So when would I suggest doing a bone marrow? And this is something that I'm sure that we could discuss afterwards because I'm pretty sure that the opinions probably differ from one physician to another. But it's generally recommended when you have really, really high blood hypereosinophilia. And it has clearly been demonstrated that people who have clonal eosinophilia tend to have statistically higher eosinophil counts in peripheral blood than those who have reactive forms. So if the hypereosinophilia is severe, if it's more than 5,000 per microliter, this might be already an interesting let's say, clue to the type of patient which should have a bone marrow done. Other abnormalities which are suggestive of a myeloid disorder, such as organomegaly, a perturbed complete blood count, elevated serum vitamin B12 or tryptase levels. These are all situations where bone marrow biopsy might be also particularly interesting. And it's the same thing, actually, if you do discover an abnormal T cell phenotype. And even in these patients where you think they have lymphoid variant hypereosinophilic syndrome because you have detected a CD3 negative, CD4 positive T cell subset in peripheral blood, it's important to keep in mind that some of these patients actually have lymphoma. This can be the same subset that you will find in patients who have angioimmunoblastic T cell lymphoma. So you definitely have to bone marrow patients who have one of these abnormal T cell phenotypes. So that is how the bone marrow investigations are positioned as far as I'm concerned. And as I said, I'd be really happy to discuss that afterwards during the discussion. Another important and I'd say more novel perspective when doing bone marrow in patients is the possibility of doing next generation sequencing and demonstrating the presence of somatic mutations, potentially that have not yet been described in this setting, or perhaps that have been described in a handful of patients, because that's how we're going to actually make progress in recognizing clonal hypereosinophilia. So many of these patients are actually at one point in time concentrated in referral centers, centers which are going to be able to perform these less routine investigations looking for polymorphisms that have been described in small subsets of patients, which are obviously not those which are related to aging, but which have been shown to be related to clonal myelopoiesis. I'd like now to share with you a few slides showing the relative distribution of causes of hypereosinophilic syndrome and or hypereosinophilia, depending on the centers which have actually looked into this. And I'm going to show you three very, very different centers with very, very different profiles. This first center is a center, this is actually Andrew Wardlaw is a pulmonologist, works in Leicester in the UK. And although he's a pulmonologist, he has really developed a reputation in management of hypereosinophilia. And as such, he receives patients for that very, very specific indication. Okay, my patient has more than 1,000 eosinophils per microliter. What's his problem? And so in this study, which was almost 400 patients over, I think it was a 16-year interval, you can see the different types of diseases that a pulmonologist with a special expertise in hypereosinophilia will receive. Obviously, as he's a pulmonologist, lots of asthma, lots of fungal allergy, because this is actually allergic bronchopulmonary aspergillosis, eosinophilic pneumonia, EGPA and hypereosinophilic syndromes. You do have a lot of pulmonary presentations here, and you can see how tiny the percentage of patients who have myeloproliferative disease forms is. And this is really someone who does a state-of-the-art investigation of hypereosinophilia. So this is a tiny, tiny subset of patients. On the other hand, this is a tertiary referral center for patients with cancer. And this data was collected by a hematopathology department in the USA, patients who are referred for hypereosinophilia, also during an almost 15-year period. Here, these were 125 patients which were collected. And just going to go through this slide step by step, just pointing out what I think is really interesting here. So first of all, there were a series of patients who turned out to have underlying cause for their hypereosinophilia, meaning that when they were sent to this tertiary referral center, this is 1 out of 5 patients who actually still had an underlying cause to be found. I think that's a first interesting message. Second interesting message, obviously this is a hematopathology department in the center with lots of expertise in the field of hypereosinophilia and clonal hypereosinophilia. And you can already see here that there's a series of patients for whom PDGF receptor alpha and or beta rearrangements were detected, as well as other evidence for myeloid neoplasms. So if you put these together with another series of patients for whom, okay, it was not obvious from the onset, from the first series of tests that they had clonal hypereosinophilia. But when you go a bit further, when you look into their bone marrow, when you look at the aspect of the bone marrow, if you're looking for other less common rearrangements and cytogenetic abnormalities, you turn out with overall in this particular setting, 41 myeloid feature patients, let's say, or truly myeloid neoplasm patients. So that's a very, very large proportion compared to the patients that I just showed you from that referral center for hypereosinophilia. And by the way, I'd just like to remind you of the existence of this disease or non-disease entity, which is hypereosinophilia of undetermined significance. You remember during the first webinar, I mentioned this particular subset where patients have persistent hypereosinophilia in the blood, no hypereosinophilia in tissue, no underlying cause which is found, no symptoms whatsoever. And so these patients do not have to be treated. They simply have to be followed up regularly to make sure that they do not develop complications of their hypereosinophilia. Third and last center, which I would like to share with you. So this is also a very, very important tertiary referral center at the NIH. They have long-standing history of expert management of patients with hypereosinophilic syndrome. And this center saw 302 patients. Well, they collected data on 302 patients who had been evaluated for unexplained hypereosinophilia. So this is a tertiary referral center, and patients who were sent had apparently no underlying etiology. And what you can see here is this little red triangle here. The very, very first important step is when this expert center tested patients for underlying etiology, they still found a significant proportion of patients who actually did indeed have secondary hypereosinophilia. So these were not hypereosinophilic syndrome patients. These were patients who did have a common etiology for their hypereosinophilia. And if you remove those patients, then you can see how the different disease variants are distributed among the remaining patients. Obviously, the biggest piece of the pie is idiopathic hypereosinophilic syndrome. And what the NIH team call overlap hypereosinophilic syndrome is actually patients who have single organ disease. So for example, chronic eosinophilic pneumonia, eosinophilic gastroenteritis, these will both fall in the category of overlap disease. And then myeloid and lymphoid hypereosinophilic syndrome, they both represent roughly 10 to 15% of patients who are referred to that particular center. And that's more or less the experience that we have here at Erasme as well, with a bit less patients who have myeloid disease variants. I said at the beginning that I would just discuss in a few slides the differential diagnosis of pulmonary eosinophilic conditions. And I think it's really important to be aware that there's significant overlap between these conditions. I'd like to highlight in this table, which kind of recapitulates the different forms of pulmonary hypereosinophilia, 3 particular diseases. So eosinophilic granulomatosis with polyangiitis, formerly called Churg-Strauss syndrome, hypereosinophilic syndromes, we've gone through that extensively over the past few weeks, and chronic eosinophilic pneumonia. I also discussed that during the very first presentation. This is a disease form where patients consistently have recurrence of disease flares, always in the form of pulmonary infiltrates, accompanied or not by sometimes pretty high blood eosinophil counts. And if you look at these 3 disorders, they really present significant overlap in terms of the type of patients that these represent. Generally, they have more or less the same age. These are patients that pretty often in the 3 disorders, so chronic eosinophilic pneumonia, EGPA, and HES, they generally tend to have very, very similar comorbidities. So atopic disorders are frequent in all three disorders. Chronic rhinosinusitis is frequent in all three disorders. When you do imaging, because they have pulmonary manifestations, you're going to see the same thing: ground glass opacities and consolidation. If you do bowel fluid examination, you're going to see the same thing: lots of eosinophils, et cetera, et cetera. And so I think it's really important to be aware that these different diseases may be very, very difficult to differentiate amongst themselves. And all the more so, if you look at EGPA, so you may have in mind, okay, why is this overlapping with HES? Because this is an ANCA-associated vasculitis. Well, first of all, less than 40% of patients with EGPA actually have ANCA. Second of all, as you probably know, EGPA progresses with different phases of disease. The first phase of disease is patients have severe asthma. It's generally adult onset severe asthma on a background of atopic disorder. At some point in time, they're going to develop blood hypereosinophilia. This is the orange here. Blood hypereosinophilia starts to shoot up in patients. And in parallel, they're going to develop eosinophilic lung infiltrates in the majority of cases. Eosinophilic infiltrates may eventually concern other organs as well at this disease phase, but it's important to know that at one point, before patients develop vasculitis, they're often going to have marked blood hypereosinophilia and eosinophilic lung infiltrates, which is exactly what we see in patients who have HES or chronic eosinophilic pneumonia. And the problem is we're not going to let them evolve naturally towards vasculitis. We're going to give them corticosteroids. And so once we started treating them, who knows who would have gone on to develop vasculitis or not? There's really practically no way as of yet to be able to differentiate these different patients. And this is just to illustrate once again the degree of overlap. In this article, we looked at the percentages of complications in HES and in EGPA in the different tissue and organ systems. And you can see that, okay, asthma has to be present practically to be able to make a diagnosis of EGPA, but it's also present in a significant proportion of patients with HES. And if you look at pulmonary infiltrates and more systemic pulmonary disease, it's really frequent in both disease forms. So lots of overlap. And I just like to underline that it's difficult to be able to make a diagnosis with a disease for which there are no clear-cut diagnostic criteria. This is clearly the case for EGPA. And so there are these, they're the classical EULAR ACR criteria, which begin with a vasculitis. And if you have vasculitis, then you can make the diagnosis of EGPA based on a score, which integrates a series of clinical and extraclinical disease manifestations and features. But there's also another way of approaching the diagnosis. It's using the criteria for EGPA that were used in the MIRA clinical trial. And these criteria can be pretty easily met in patients who have HES or chronic eosinophilic pneumonia, because besides having to have asthma and at least 1,000 eosinophils in the blood, you can have any two of the following. And I highlighted in green things that you're going to be able to see in patients who have all three disorders. And then just recently, I have a student who did his master thesis on the topic of overlap between these different conditions. And you can see how extensive the overlap between HES, CEP, and EGPA are if you use the current accepted diagnostic criteria for these disorders. And this overlap is actually pretty interesting, and I'll explain that later on. But you can see here that so the EGPA MIRA criteria are present in many, many patients. Those who are not in these criteria, generally the problem is they just don't have asthma. But if you have HES and asthma, it's pretty easy to fall into the MIRA diagnostic criteria. And we're going to see later on why this is interesting for patients and access to targeted therapy. So now let's discuss therapy. How do you manage the most severe and acute presentations? I'd just like to get this slide over with because I think it's important that you be aware that sometimes patients come into the emergency department with acute heart failure because they've had hypereosinophilia, which has been neglected. And obviously, this is life-threatening. You're not going to take weeks and weeks to go through the causes and consequences. The diagnostic evaluation is going to be extremely limited. You're going to give empiric treatment with high-dose steroids. And eventually, if the patient may have traveled to a country where he may have been exposed to streptococcus infection, given the fact that you're going to be immunosuppressing with the high-dose corticosteroids, you're also going to be preventing hyperinfestation syndrome by giving ivermectin, sorry. Otherwise, if the patient does not have clinical manifestations, very rapid reminder, if you don't find a secondary cause for this hypereosinophilia, you're going to consider this as hypereosinophilia of undetermined significance, and you're going to monitor the patient and not give therapy. So just please remember that. And then there's this other situation. I have to keep this one here for 1 second, where although the patient does not have clinical manifestations, you do find evidence that the patient has MHES. For example, the FIP1-like1 PGF receptor alpha rearrangement is present, but the patient is asymptomatic. Well, in that very particular situation, you're going to treat the patient, even if he has zero symptoms, because he's going to develop them, and they may be very severe and very, very rapid in their progression. So even that kind of asymptomatic patient you're going to be treating. And it's the same thing if the patient has features of myeloproliferative disease. And these are the features that you have to look out for. And if they have at least 4 of these features, you are going to try to treat the patient with some form of tyrosine kinase inhibitor, and it may work in some of the patients. And now I already mentioned this. Okay. What are the classical treatment options according to disease variant? We're going to begin with myeloid variant hypereosinophilic syndrome, and more specifically, disease which is associated with that FIP1-like1 PDGF receptor alpha rearrangement, because that is by far the most frequent anomaly that you're going to be picking up in patients with clonal hypereosinophilia. There's absolutely no discussion. These patients respond exquisitely well to Gleevec. Low-dose Gleevec, they only require 100 milligrams per day. You can actually begin treatment with 100 milligrams. It's going to work in practically all patients. The primary refractory cases, I mean, you can almost count them on the fingers of one hand. It's very, very uncommon. And then sometimes patients have secondary refractory disease. This is also very uncommon, but these are patients for hematologists. They're for you guys. They're for specialists. Besides that, you have patients who have other forms of clonal eosinophilia. And once again, as I already mentioned, Professor Breccia discussed this in a great degree of detail. I will not discuss this here. This is for hematologist referral and eventually inclusion in clinical trials, because some of these disorders are really, really difficult to treat. In all other conditions, the first line treatment is going to be corticosteroids. So if you have a patient who has idiopathic hypereosinophilic syndrome, lymphoid hypereosinophilic syndrome, you're going to give corticosteroid treatment, and you're going to taper down treatment to the lowest possible dose, which is going to ensure disease control. Unfortunately, in many cases, that dose is too high. Patients require lifelong treatment, as you know, and so you're going to have to consider introducing second-line treatment options to be able to further reduce and eventually withdraw background corticosteroid therapy. In a patient who has lymphoid variant hypereosinophilic syndrome, this is data that I showed previously in the second webinar, if I'm not mistaken. These patients respond particularly well to interferon alpha. Interferon alpha acts not only directly on the eosinophils, but also on the clonal T cells, which are driving disease. So it's a very, very interesting treatment option. Unfortunately, in Belgium, absolutely unavailable for these patients. They have to pay for it from their own pockets if they want to take it. As for idiopathic hypereosinophilic syndrome, generally the first line treatment, well, not this first line, but the second line treatment option, which is proposed, is hydroxyurea, because it has been shown to be effective. You begin with pretty high dosing, and then if the patient becomes stabilized, generally you can taper down hydroxyurea and corticosteroid dosing with a pretty satisfactory disease control for a while. The problem is, and this slide really highlights how significant this problem is, many patients do not tolerate these second-line treatments. This slide is actually taken from a retrospective multi-center study that was performed on almost 200 patients from very different countries and centers. And you can see here in the middle, patients who received hydroxyurea, patients who received interferon alpha. More than 3/4 of the patients had to stop treatment. And the reasons they had to stop treatment was pretty much equally distributed between lack of efficacy and medication intolerance, with a bit more intolerance for interferon alpha for pretty obvious reasons. So these second-line treatment options are actually not an option, because generally they just don't do the job, or patients can't take them because they don't tolerate them. So there's a very, very important unmet need corticosteroid tapering therapy in patients with hypereosinophilic syndromes. And this unmet need was addressed by studying the impact of eosinophil targeting therapy in these patients. And this is what I'm going to end the presentation with. So at the first webinar, I showed how important IL-5 was in the eosinophil biology. IL-5 is important for eosinophilic, but it's also important for chemotaxis, activation, survival in the periphery. Basically, it's the cytokine which enables eosinophils to survive, to expand, to be activated, to degranulate. It's a very, very central cytokine in the life cycle of the eosinophil. And several monoclonal antibodies have been developed to target IL-5 or its receptor. You can see here on the upper right, restizumab and mepolizumab. These are anti-IL-5 monoclonal antibodies, whereas benralizumab is an anti-IL-5 receptor alpha monoclonal antibody. Restizumab and mepolizumab act by starving eosinophils for IL-5. And so they're deprived of this critical cytokine for their life cycle, whereas benralizumab acts by actually destroying eosinophils by ADCC. So once benralizumab has attached to the receptor, which is expressed on the surface of eosinophils, it's going to attract killer cells, which are going to kill the eosinophils and deplete them in a very, very drastic way, both in the blood and in tissue. So the only drug that has been approved so far that targets eosinophils for hypereosinophilic syndrome is mepolizumab. Mepolizumab is one of those anti-IL-5 monoclonal antibodies, and it was tested recently in a randomized clinical trial. This clinical trial enrolled patients who had uncontrolled disease. So they had to have more than 1,000 eosinophils per microliter at the screening visit, and they had to have had at least 2 flares within the past 12 months before their enrollment. So that's active disease. Throughout the 32-week period during which this randomized controlled trial was conducted, their background therapy had to remain stable. So these patients are basically on a starting block. They're ready to flare, and then you randomize them to receive either mepolizumab 300 milligrams subcutaneously every 4 weeks or placebo. And you look to see the proportion of patients who have a disease flare. I just want to add in passing, obviously, these patients had to be FIP1-like-1 PDGF receptor alpha negative because those patients are not eligible for this kind of therapy. They're eligible for tyrosine kinase inhibitor therapy, obviously. And so the proportion of patients who flared during this 32-week period was the primary endpoint. And as you can see on this slide, this endpoint was well met with a very, very nice statistically significant difference between the proportion of patients who flared, which was 50% lower in patients who received active treatment compared to those who received placebo. You can see here the cumulative incidence of flares, and you can see it was a lot lower in the mepolizumab treatment arm. And if you look at the annualized rate of flares, because this was a 32-week period, so if you look at a 52-week period, there was a 66% reduction in the incidence of flares. I'd also like to show this slide, which is from another study. It's a very, very old study that was conducted in 2004 with another dose of mepolizumab, 750 milligrams given intravenously, also every 4 weeks, also against placebo. And the design of the trial was very different. These were patients who were controlled when they entered the trial, but to be able to achieve disease control, they had to require between 20 and 60 milligrams prednisone. And once they entered the trial, the background dosing of corticosteroids was tapered down, and it was an oral corticosteroid sparing, let's say, clinical trial. And what you can see here, this was not the primary endpoint, but it's a very, very interesting endpoint, is these patients who were corticosteroid dependent between 20 and 60 milligrams at trial entry. You can see here the dose that they required at the end of the study, after 52 weeks inclusion in the trial. You can see that roughly 50% of patients in the active treatment arm were no longer receiving corticosteroids whatsoever, and that the median corticosteroid dose in the whole group of patients in the active treatment arm was 6 milligrams against 21 milligrams in the placebo arm. This was a very, very significant difference, obviously, and clinically extremely meaningful. Last slide on the clinical trial. This is coming back to the more recent clinical trial, which gained approval of mepolizumab for hypereosinophilic syndrome at the dose of 300 milligrams every 4 weeks. This was an interesting outcome. It was on fatigue. So it was a kind of secondary or exploratory outcome in the trial. And I'd just like you to focus on the last set of histograms. So these are patients who, when they were enrolled in the trial, had more than 2,500 eosinophils in peripheral blood. So I said they were on the starting block. These patients were really, really on the starting block for a disease flare. Those who received placebo, by the end of the study, were either more tired, this is in pink here, the worse they feel in terms of fatigue compared to their baseline visit, the pinker it is. Either they were more tired or they were just as tired as when they entered the trial. And those who received active treatment, as you can see, a significant proportion of patients felt less tired. And that's amazing because that's really something that's difficult to see over only 32 weeks in a clinical trial, comparing two drugs in a chronic inflammatory disorder. I find this a really, really amazing outcome of this trial. So coming back to the figure I showed you before, when should you consider eosinophil-targeted treatment in hypereosinophilic syndrome? Well, as far as I'm concerned, once the patient has received corticosteroids, appears to be corticosteroid responsive and dependent, which will be the case in many of the patients, there's really no need to wait and to make the patient go through the hassle of these second-line treatment options, which are not very efficacious, which are not very well tolerated, and you should immediately go for eosinophil-targeted therapy. If it doesn't work, then you can go back to the other second-line agents, and probably you're going to have to look for some of those more potent and more novel agents like JAK inhibitors. I discussed that a bit during the presentation on lymphoid variant hypereosinophilic syndrome, but there's really no need to wait if you have a patient who is corticosteroid dependent. I'll just end by underlining the fact that in terms of treatment of these disorders, there are still many, many open questions and unmet needs. These were summarized in a recent article in the Journal of Leukocyte Biology. This is a very heterogeneous disease. We have really no standardized means of looking at disease outcomes. There's been no definition of what's a remission. There are no biomarkers which parallel disease activity which we can follow to make sure that patients are responding to treatment. How can we predict which patients are going to respond to which targeted treatment options? I mentioned that patients with lymphoid variant hypereosinophilic syndrome seem to respond less well to eosinophil-targeted therapy. It's pretty logical because it's actually a T-cell driven disease, but there are also other non-responders. On the contrary, there are some super responders to these eosinophil targeting drugs. How can we predict which patients are going to respond extremely well, exquisitely well, or not that well? These are all very, very open questions. And then as the future evolves, we're going to be increasingly probably combining treatments, combining anti-type 2 inflammation treatments, and how is this going to eventually impact safety? Can we give these drugs to women who are pregnant, et cetera, et cetera? So we still have really lots of questions that remain unanswered and that we should definitely strive to answer in the following years and pretty rapidly. I'll leave you with these take-home messages, which are basically a summary of what I already told you, but perhaps I can just point out a few different points. Just please also remember that some patients have asymptomatic hypereosinophilia. You need not treat them. I have a few patients like this. You just have to follow them over time. And if they develop complications, obviously you need to treat them very, very rapidly. But don't treat them just because you want to treat the blood test. Also, if you have a patient who's referred for hypereosinophilic syndrome, please also make sure that the workup for secondary hypereosinophilia has been complete or completed by yourself. You really have to look twice and make sure that the initial evaluations were sufficiently thorough. Otherwise, patients with hypereosinophilic syndrome, these are patients who are going to be requiring lifelong treatment in the majority of cases. So you really want to give them treatment which is going to harm them as little as possible. I have patients who have been receiving corticosteroids for all their life and all my life as a physician, and I've seen how poorly that has impacted their general health. And so I'm really delighted that now we have options which are really targeting eosinophils, extremely well tolerated. There are more and more options that are being studied right now, which will probably be available in the following years. So be attentive to what's coming out in the field. It parallels the field of asthma with a few years of delay, obviously, after those other more common type 2 disorders. And also, please keep in mind that these treatment options, they don't actually treat the disease. These are just suspensive. If you stop them, the hypereosinophilia is going to come back. It's a question that many patients ask, and you have to be able to upfront warn them of this possibility. With that, I'd like to thank you for your attention, and I'd be really happy to discuss any aspects of patient management that you may have.
Thank you very much for your presentation and your expertise. It's wonderful. And thank you, everyone in the audience. There's a great turnout. So we have a couple compliments regarding your presentation, of course, and then we have a couple questions as well. Starting with the first question, it says, thanks for your brilliant presentation. What investigations would you suggest in case of untreatable secondary cause? Inflammatory bowel disease, very active, plus some light allergies and persistent high EOS count, greater than 20 to 30%, greater than 2 in absolute numbers. Would you do bone marrow mutation screening?
Yeah, I mean, that's a really good question. And we do get quite a few of these patients. This is what Amy Cleon calls associated HES. And it happens quite commonly in patients who have ulcerative colitis, for example. I generally do not do bone marrow sampling in these patients, and I might be impacted by the fact that I'm an internist and not a hematologist. What I can say is that when I receive these patients who have first gone through a hematologist and who has done a bone marrow, it's always reactive hypereosinophilia. But I mean, there's no reason not to do the classical FIP1-like-1 mutation on peripheral blood in such patients. I think it can remain useful. It's also very useful to check if this colitis, for example, and the hypereosinophilia are associated or not. Some patients truly have two disorders, but those who have colitis associated with a hypereosinophilic component, you're going to have a lot more eosinophils in the gut biopsies than you would expect for a normal case of ulcerative colitis. And the patient is generally going to have a parallel evolution between the flares of colitis and the hypereosinophilia in the blood and in tissue. And when it's like that, I think it's really interesting to be able to eventually propose eosinophil-targeted treatment in addition to what the patient is actually receiving for the ulcerative colitis. And I have a couple patients like that. I hope I answered the question.
Great. Thank you for the answer and thank you for the question. We have another question. Do you have any experience with eosinophilia secondary to PDI inhibitors and the name of pembrolizumab? Sorry for the pronunciation.
It has been described. So, and I was actually called last week for a patient who developed hypereosinophilia in that very setting. Yes, it happens. And if you look in the literature, you will find cases of eosinophilic pneumonia, of eosinophilic fasciitis, of isolated blood hypereosinophilia. I think the idea is it's similar to what you see when you have these other inflammatory conditions which developed in patients who have immune checkpoint inhibitors. Probably these are patients who have some degree of dysregulated immunity, but you all know that we also have very nice regulatory cells which are constantly protecting us against inflammation. And probably that these patients who are predisposed, they may have some form of polymorphisms or whatever. They might have barrier defects, and this additional hit, which is represented by an immune checkpoint blockade, can eventually be the trigger for development of hypereosinophilia and or even sometimes a hypereosinophilic syndrome or hypereosinophilic condition. Yeah, for sure.
Great, thank you so much. We also have a comment regarding the first question.
Yeah.
They actually seem to be associated, exclamation mark.
Yeah.
Flare-ups with
Absolutely.
higher eosinophils.
Yeah, so in my experience, my few patients that I follow who have ulcerative colitis and hypereosinophilia, they have too many eosinophils in their colitis, and there's a clear parallel in terms of clinical progression. And I actually am lining up one of my patients like that right now for Nucala, because he's clearly he checks all the boxes for for the inclusion criteria to be able to receive the reimbursement criteria, sorry, to receive mepolizumab. I don't know if he's going to be better though. That would be a future webinar.
Okay. And we have another question from the person that asked the second question. Would you treat the eosinophilia related to PDI inhibitor if the patient is asymptomatic?
No, I would really do exactly like I would do for what I showed on the algorithm. So if the patient is asymptomatic, obviously you have to be very, very careful for the heart. You have to do serum troponin. I would even go for the cardiac MRI. I would follow serum troponin on a regular basis, but I would not just treat the blood test. It's really similar to hypereosinophilia of undetermined significance. It's kind of like also you have patients who receive dupilumab nowadays, which is an anti-IL-4 receptor agent. And because of the impact of IL-4 on integrin expression, many patients who receive dupilumab, for example, for atopic dermatitis, develop blood hypereosinophilia. And it's never a problem because these eosinophils don't go into the tissues. Well, no, never. I'm sorry. I should not say never. There have been case reports where patients actually do develop complications in that setting, which is why you have to look for complications. But in the majority of cases, this is blood hypereosinophilia, which does not warrant treatment. And it's really important to be aware of that. You have to know it can be deleterious, and you do have to be thorough when you're investigating complications, but you don't treat the blood test.
Right. And then there's a follow-up question to that. And would you still study the patient for clonal myeloid disorders?
So is that the one which develops with the immune checkpoint blockade? Is that this related to that question with the pembrolizumab?
Yes, according to the expert.
Well, personally, probably not, because it's reactive, it's developing in a setting. Once again, this is completely out of the, these are not in the official recommendations, but another interesting little test you can do, does this respond to corticosteroids or not? If it does, okay, it's reactive and it's not something you should be too worried about. That's a pretty good test in terms of the clonality of eosinophils.
Great. Have a response. Thank you. Perhaps we have time for one more question. Oh, here we have one. How much corticosteroids would you use for what time, I believe?
So that's a very general question. Is there a specific circumstance in mind, or is that overall?
Just added to assess response.
Oh yeah. I don't know. A few days. Yeah. Just a few days. And in terms of the dosing, I'm just making things up as I go along here. But if you want to test, you might as well test well. So I'd say something like, anywhere between 0.5 or 1 milligram per kg and for 5 days and check the effect. Something like that.
Right. Thank you so much. And perhaps one last quick question. We have another comment. Thank you very much. It was very interesting and informative.
Thank you.
Given the amount of expertise and the audience and the attendance, it's in many ways, it's a shame that it's the last of the webinars. But thank you very much for expertise and for culminating and wrapping up all of the previous webinars. So on behalf
It's a pleasure, really.
Yeah. So thank you so much. If there's no more questions, I think we'll call it a wrap. But thank you once again for your expertise, and thank you all for your participation, for all your engaging questions. It's a real pleasure. I have one last comment. Thank you. Fantastic spotlight.
Okay. Thank you very much. Thank you for your interest and in the interesting discussion. Have a nice evening, everyone. Bye-bye.